record the class, but please, I always say record yours, just in case this doesn't work. Good morning. Last week, we talked about COPD. Tell me what you remember. No more than 2 liters of oxygen. What else? Please, everything you're telling me, tell me about patient care, like she did. No more than 2 liters of oxygen. I don't want to hear anything patho. It has to do with patient. Safety, patient. So what else? See the patient up to help expand the lungs so they can breathe better and improve their oxygenation. What else? Incentives parameters for lung expansion. It also helps the patient to do what? What else does it help the patient do? Improves secretion and what else? Coughing. It helps the patient to cough. What else? Increase fluid intake. How much fluid intake? 2 to 3 liters a day. To thin what? The sputum. What impact does it have in the patient? When it thins the sputum, clears the airway, they'll be able to spit it out so that the airway is cleared. It's all about maximizing oxygenation, right? When the airway is cleared, they can take in more oxygen. What else? That was 2-hour class, yeah. 6 more meals a day. Why?
They might have a hard time getting food down because they're having a hard time breathing.
Because they're having difficulty breathing. Because of hypoxia, hypoxemia, it tends to increase their metabolism. It increases their respiratory rate. Therefore, it makes it harder for them to eat and chew food. Therefore, small frequent meals becomes an alternative way for them to get their nutrients in. Snacks, they can, pick at any time of the day to eat. What else? Forcefully breathing. What impact does it have on the patient? You don't have to be you. Anybody else can answer. You already said forcefully breathing. Anybody else? What impact does it have on the patient? It helps to expel more CO2 when you're having forcefully breathing. It prolongs exhalation. Because it prolongs exhalation, it increases the amount of CO2 that you exhale. What else? Teaching a patient about smoking cessation, because cigarette is the #1 cause of what? COPD. Therefore, you need to educate them on smoke cessation. So how do they do that? How do you do smoking cessation? What can you help the patient do with that? Educate them they are a patch or chewing gum. Let those patients work with community outreaches, other people that smoke or trying to quit. Educate the family to help the patient. What else? What else? Try to cough and deep breathe again, clearing the airway because of the thick sputum, bronchitis aspect of the COPD. Send those patients home on those 2 liter, educate them on the precautions to take, right? Because they will be smoking, or the family member that will be smoking, educate them not to smoke around the time, right? Okay, continuing again, continue with oxygenation. This time is asthma and COPD. I'm putting up the SLO again, I'm not going to go through that again. We did that last week. Just to remind you that if I were you when I study based on SLO because that helps to guide the test. That's why I'm spending time on that. When you're looking at assessment, you're looking at how do you assess this patient. What impact does that do? What am I looking for? If I find that this patient has COPD or the lungs is not clear, what is my intervention? When you're looking at prioritizing actual and potential problems, I'm analyzing the patient lab values. I'm looking at the patient medication. What impact does this medicine have on the patient? What are the precautionary measures I'm going to take when I'm giving certain medication? If the patient taking medicine A, can they take B with it? Those are prioritizing and the analysis, actual and potential problems, because if you give patient medication that they're not supposed to take because of the disease they have, it's going to cause harm. This is how you study. Don't skip anything because you don't know where the question is coming. And the question touches everything. It touches the lab values, it touches the medication, it touches the patient as signs and symptoms. It touches all the contraindications you might have in certain medicine. Like I tell the student all the time, any medication the teacher talks about in the class, if I were you, I study those medications because we cannot know all the medicines. We are not as Xavier. Xavier is where you learn pharmacology. Therefore, we have to pick certain medications that we feel like are very relevant to the concept and discuss them. So pay attention to those medications, learn everything about those medications. If they are contraindicated, know them. Know their mechanism of action. What can you, if the patient is taking X, can they take Y? Kind of thing. Do you take the medication on empty stomach or you take them with food? What are the signs and symptoms of this medicine? Does it increase blood pressure, reduce blood pressure, increase fluid retention, reduce fluid retention, increase sodium, reduce sodium, increase potassium, reduce potassium? That's how we need to know that because it has to do with how you give the medication and the impact it has on the patient. You will be able to create measurable and achievable short-term and long-term goals. Okay, the patient have asthma exacerbation, comes to the hospital. They have breathlessness, they are panting, they are agitated. What will you do first? What are the implications of what your intervention? What am I going to do first? This is before the patient presented to me or is presenting to me. What am I going to do to resolve this problem so that those patients don't end up having respiratory failure or status asthmaticus and end up in ICU? What am I supposed to do with that? So we're going to learn about those today. Evaluate concept and example based on nursing collaboration, collaborative intervention. Again, this is oxygenation. You cannot function in teaching a patient oxygenation without incorporating respiratory therapy because they are the ones that give most of the medication via inhaler. Because medicine, when they are having exacerbation, which is what brings them to the hospital, they need inhaler. They need those nebulizers. They need to take their medication through inhaling it because that's where it works faster than them taking pills. So we have to incorporate respiratory therapy in this. Always remember there is already order for you. Patient already signed consent for respiratory therapy to take care of them. I can't believe at this stage the student is still telling me, but I need order for X, Y, and Z. Forget that. You are in level 2. Your patient is med-surg. They already passed through the emergency room. They already have order for you to take care of them. Every question we're asking you, the patient already have order for them. So 5, evaluate expected patient responses and progression and effectiveness. It's not enough, again, I always say this, to treat the patient, to teach the patient how to use their inhaler. How do you know that they know how to use their inhaler? They return demonstration to you. How do you know that this patient that came in with asthma exacerbation, with breathlessness, SO2 90, the patient is coughing, the patient is wheezing? How do you know that the inhaler you gave works? How do you know that the respiratory therapist treatment works? That's why if you watch a respiratory therapist, they go in the patient room, the first thing they're going to do, they do pulse ox. They assess the patient lung. Then they give treatment. When they finish treatment, guess what else they do? They assess the pulse ox again. They reassess the patient lung sound. What are they doing? They're trying to see if the treatment they gave the patient works. If I'm hearing wheezing before I give nebulizer treatment, I need to know, did the wheezing reduce when I am after treatment, or the patient is still wheezing bad? They need to know that. Because after reassessment, they realize that their implication is not working. They will let the nurse know, look, I think this patient needs another medicine added to this. Because their evaluation tells them the medicine is not working for the patient. It's not enough to intervene, you have to reevaluate. Okay. Continuing today, how many of you have seen anybody that have asthma, or they have asthma themselves, or they have family member that have asthma? Anybody? Okay. You have asthma or family? Okay. So tell us what you know about that. hard to breathe, so they have breathlessness. What else? Anything else that she does? She wheezes. Anybody else? Anything else? Does she cough? Mm-hmm. Anybody else? You raise your hand.
Yeah.
You have asthma or somebody you know?
My sister has asthma.
Mm-hmm. They do a top-knee position too. Use of accessory muscles. What else? Anybody? Anybody have taken care of patients that have asthma? Anxiety. They have severe anxiety, apprehension, they have mood swings, they have agitation, they have chest tightness, they have feeling of doom, okay. When a patient has asthma, asthma is an inflammatory response of the airways. Anybody that have asthma have inflammatory response already on a daily basis. They have mild edema already on a daily basis. But those inflammatory responses and mild edema tend to be dormant. That's why they don't feel any signs and symptoms that we listed until they have what? What is the word I'm looking for? Anybody? Until they have a trigger. What does the word trigger, English word, means? What is a trigger? Something that causes something to happen, right? So when patients have asthma, it is the trigger that exacerbates the inflammation. They already have inflammatory response. That's why it's only the trigger that stimulates all those neutrophils, lymphocytes, eosinophils to be excreted in the body, causing harm. Those are the labs you must remember when you're talking about asthma exacerbation. You have to look at eosinophil, neutrophils, and lymphocytes. Those are allergic responses to triggers. The body will secrete that. When you go to the hospital, the doctor must do CBC. CBC with differential. They must do CBC with diff. It is that differential incorporates eosinophil, lymphocyte, neutrophil. It's not just CBC. It has to be complete blood count with differential for patients with asthma because they're looking for that aspect of allergic reaction incorporated in the CBC. Most of you that work in the hospital know that. You may not know. That's why they do CBC with this. Sometimes the doctor will say, oh, I need CBC on this patient. Then they will forget. They'll come back and say, oh, I need CBC with this. If they're not looking for allergic reaction on the patient, they can just do complete blood count. But if they're looking for allergic reaction, which is what they do with patients that have asthma, because asthma is nothing but allergic reaction of the airway, inflammatory, not allergic, inflammatory responses of the airways. So when they're looking for those inflammatory responses, and then they're looking at what the body secretes during inflammatory response, they're looking at those CBC with this. Eosinophil, neutrophil, lymphocytes. So, these patients that have asthma, like I say, already have inflammation on a daily basis, but the inflammation remains dormant. Just like when you have TB, you have what you call dormant TB. Did you all discuss that in the TB? Dormant TB, they have the TB, but it's dormant. It's not active. It becomes an illness or disease when it's active. That's the time they have signs and symptoms, they can infect somebody. The same thing with asthma. Those patients have inflammation on a daily basis. But those inflammatory responses are dormant in the body. They're not activated, they're not causing any harm until they meet a trigger. That's why trigger depends on something that's already there for you to trigger something else. There's already inflammatory response, they're waiting for trigger. So for your mom, what is her trigger for, what's your name? What triggers her asthma exacerbation? Okay, okay. So your sister, what triggers her exacerbation? Triggers her asthma?
Dust and pollen.
Dust. So triggers. Dust, pollen, air, cold air. What else? Chemicals, medications, perfumes, dead roaches, believe it or not. What else? Huh? Exercise. There's medication. Gastroesophageal reflux diseases can cause that. Stress, yes. Smoke, fumes. Cigarettes, can fall under fumes. Stress, yes. So, the goal of asthma becomes to avoid the trigger, because it is the trigger that wakes up those inflammatory responses. It is the trigger. When it wakes up those inflammatory responses, it manifests on the patient as these signs and symptoms that we listed here: breathlessness, chest tightness, wheezing, coughing. So, as the body secretes those inflammatory responses, it causes edema to the airways. It causes the airways to constrict. They have bronchoconstriction. When you have this constriction of the airways is like squeezing. That's how the patient feels, like his chest tightness. They feel like this feeling of doom. You have decreased oxygenation getting to the alveoli. The airway is tightened and squeezing. There is bronchoconstriction of the airway. Unlike in the COPD, you have a sputum occluding the airways. There's no bronchoconstriction. In asthma, you have bronchoconstriction of the airways. This bronchoconstriction stimulates so many things. Causes edema of the airways, causes narrowing of the airways. The patient feels breathlessness. They feel tight. They feel like they don't know when the next air is getting to them. They have this feeling of doom. That's why they end up having a lot of severe anxiety, because they don't know when the oxygen is getting to them. They take in breath, but breath is not getting anywhere. They tend to wheeze. Wheezing is associated with asthma. They tend to wheeze because of that narrowing of the airways. They are very tachycardic, tachypnea, in an attempt to increase more oxygenation to get to the lungs because of that bronchoconstriction of the airway. Okay. Let's start from here. These three lines, tell me what you have learned so far. Relate it to the patient like I did. The three over there, the three lines over there, tell me what you have learned so far. Anybody? Eh? Right. The inflammatory process is already dormant. It takes a trigger to put the patient into exacerbation. What else? These two lines. What else have you learned? No? You have said something. You have said something. The other 6. Same. You need CBC with DIP to look for allergic reactions, right? Okay, these two lines. The best way to avoid asthma is to get away from the triggers. Okay, the last line. What have you learned so far? That's 7 of you. Right. Asthma is bronchoconstriction as opposed to COPD is just thick sputum occluding the airways or damage to the alveoli. When you're talking about asthma, it's constriction, bronchoconstriction of the airways. So when you have that bronchoconstriction, how does it affect the patient? Anybody? Huh? Hunger. So what else? Huh? Feeling of doom. What else? Huh? Chest tightness. What else? Anxiety. What else? I'm sure you can read. I'm very, very positive you can read what I put on the board. Confusion. So when there's that chest tightness, it's all about airways, right? When you have bronchoconstriction, is the patient getting adequate oxygenation? No, when they don't get adequate oxygenation, what does it do to them? It presents to them as these signs and symptoms. They start wheezing, tachycardia, tachypnea, breathlessness, feeling of doom, anxiety, apprehension. All those signs and symptoms are listed on the board is because of lack of oxygenation, because of a constriction of the airways, bronchoconstriction. Believe it or not, we have finished that class. There's nothing else to talk about. Nothing. Okay, so let's make sure we understand this. Can I erase this side? Okay, now we have listed all the signs and symptoms. What are we going to do about them? What are your interventions? The patient with asthma comes to the hospital with breathlessness. What will the nurse do? Give them oxygen. Again, with asthma, you can give them more than 2 liters of oxygen. They can have more than 2 liters of oxygen. But if you go in the patient room, always remember, when you go in the patient room, you cannot give more than 2 because that's what the State Board of Nursing allows you to do, even with a patient that have asthma. But they can have more than 2 with order, with doctor's order. Do we understand the difference? Okay. So this patient can have oxygen via face mask. They can have oxygen 10 liters via face mask or non-rebreather mask. They can have oxygen various ways. As opposed to patient with COPD can only have oxygen via what? Nasal cannula. No more than what? 2 liters. So this patient can have more with asthma exacerbation. What is exacerbation? What does the word exacerbation mean? Worse, right? So like I said, once they have that trigger, they're going to have asthma exacerbation because they're going to begin to have these signs and symptoms we have listed here. And these signs and symptoms is what brings them to the hospital. These signs and symptoms is what we are going to target and treat because that's what brings them to the hospital for us to treat them. So breathlessness, sit them up. Sit patient up. Give oxygen as ordered or give them oxygen. Then breathing treatment. They have to have their breathing treatment. We'll talk about medication next after this. But they need their breathing treatment to be able to open up their airways. With wheezing is the same thing. They need their breathing treatment. Assess lungs. Don't underestimate assessing the lungs because you have to know what's going on with the patient so that when you intervene, you go back to reevaluate, you can compare the before and after your intervention. Coughing. Those patients have a lot of mucus, but their mucus is usually thin. They cough a lot. They have mucus. So what is this mucus doing to their airways? Blocking what? Oxygenation. Not only is blocking oxygenation, anytime you have moisture, what are they high risk for? Infection. There was a time we have a patient with asthma in the hospital. Her WBC was high. She was coughing, a lot of sputum. The doctor went ahead and put her on IV antibiotics anyway. She doesn't have fever, no fever. Why do you think she was an IV antibiotics? Huh? Why is she on antibiotics, period? What did I say happened to the WBC? It was high, right? When you have high WBC, what does that mean? Infection. We have to connect these dots here. When the WBC is high, it's an indication that the patient has infection. You don't always have to have fever for the doctors to intervene, especially patient you know that is coughing up a lot of sputum. That tells you there are more sputum to come, and you already know that when you have sputum, it is high risk for what? Infection. It is a moist environment, a breathing ground for infection. It's already showing you that because the WBC is what? High. Therefore, you need to start that patient on IV antibiotics. They don't have to wait until the patient has fever to know that they have infection. Elderly patients, most of the time, they don't have fever. Do you know how you know a patient, elderly patient is very sick? When they start having altered mental status. It's a classic indication they might have infection. It may not show as fever, but they'll start getting confused, trying to climb out the side rail. Then the nurses, instead of checking the patient's lab values, assessing the patient, they're going to strap the patient, talking about this patient is trying to climb the bed. They're going to hurt themselves. No. Treat the underlying cause of the problem. Assess the patient, then you're going to realize the WBC is what? High. Report it to the doctor will order antibiotics, give it to the patient, you see that everything comes back. So it's not always when people are agitated, means they are crazy. Agitation is lack of oxygenation. Patients that have asthma that's agitated, apprehensive, mood swing, it is lack of oxygenation. You have to watch those patients closely. When they start putting their IV out and trying to fight somebody. The patient we had last week or 2 weeks ago that have asthma, she was on the phone fussing at somebody. And we were right there giving her IV medicine. She was fussing the whole time. We kept doing what we're doing. She kept doing what she's doing, which was fussing at somebody. This is that same patient that fainted that the nurse didn't do anything about. She's taking prednisone that causes mood swing. So she's constantly fussing at somebody. But as a nurse, I already know what she was doing. That's why we keep doing what we do. As long as she allows us to do what we're doing, I don't care about you fussing. You can fuss all you want. Because I know what is triggering this. Prednisone can make patients have mood swings. So they constantly in between, they're happy, they fuss, which is what she did while we were there. She was smiling at us, telling us about her disease process. The next thing she talks on the phone, started fussing at somebody or over the phone. Didn't you do this to the child or whatever? Why? Because the medicine is making her do that. This is patient that come to the hospital with asthma exacerbation that ended up fainting, intubated, transferred to ICU, and back to the floor. Asthma exacerbation is not a joke. If it's not treated or it's not watched closely, that patient is going to end up in ICU. Again, just because you're giving treatment doesn't mean it's getting better. Somebody missed that chance of watching the patient, making sure that the treatment you're giving, whether it's working or not. In this particular patient, it didn't work. As she was telling the nurse, I can breathe. The nurse went, oh, well, you're talking. You're breathing. You're doing fine. The patient fainted and was transferred to ICU, was intubated. This is not a joke. This happened in the patient we had 2 weeks ago. And she came in with asthma exacerbation. There's no reason for this lady to be transferred to ICU. Most patients that have these chronic illnesses like asthma, they understand what's going on with them more than the doctor ever will tell them. Because it's a chronic illness, they already know how they feel. They know when they are very sick. They know when they're just sick just to get by. They understand their body more than anybody you can think of. Pay attention to those patients. Okay, so within the same intervention with breathlessness, it is important that we watch this patient. When they come in with that asthma exacerbation, because of the bronchoconstriction of the airways, they are going to wheeze. Therefore, wheezing becomes a normal response for asthma when they're having exacerbation. It is important that we pay attention when there's absence of wheezing. Absence of wheezing does not necessarily mean that they're doing better. Absence of wheezing might mean complete what? Occlusion of the airways. It becomes a medical emergency. So if they start wheezing, all of a sudden, you can't hear the wheezing. Because when they're wheezing, in as much as they don't have adequate oxygenation, they're still able to exchange some air, gas. Something is moving in and out. It may not be adequate, but something is moving in and out. But absence of wheezing or inaudible, you can't hear it anymore. You need to check that patient, because they might be going into respiratory acidemia. We're going to talk about acid-base balance with that. So it becomes life-threatening, and those patients can die. You might think, oh, the patient is doing fine. He or she is sleeping. I can't hear the whistle anymore. Let me not turn the light off. I want her to sleep. She hasn't been sleeping all day. Please, flick that light off. Always turn the light off in your patient room. I don't care how much the patient forces. Oh, I don't want that light. The nurse says, I will be like, sir or ma'am, I'm going to turn this light on so I can see what's going on with you. But I guarantee you when I'm finished, I'm going to turn it off. They will let you do it. But if you start arguing with them, then they say, don't turn it on. Just let them know that you turning the light on is for them. I'm going to turn the light on so I can see how you're doing. I'm going to turn the light on so I can assess your skin. Do you realize that the patient that have asthma exacerbation can have cool, clammy skin? Because oxygenation and perfusion are like husband and wife, y'all, that are in good terms. So if you have less oxygenation, less perfusion. You have less perfusion, you're going to have less oxygenation. You have perfusion, you don't have adequate oxygenation to perfuse through the rest of the body. You're going to be cyanotic and cool and climby. I can't see all that. I'm not Jesus Christ. I can see it until I turn the light to see how your skin is, to feel you and touch you. So don't let the patient talk here. That's one of those things. I usually obey the patients, but this is one of them. I kind of find them out on that. No, I need to turn this light on. I need to see what's going on. Or you have surgery. I am not going to be able to assess their sight if I don't turn the light on. There are occasions you go to the patient room, the whole bed is full of blood. They don't even know it because they were sleeping. Why? Because nobody turned the light on to see that the bed is saturated all the way to the sheet. Nobody saw that. But the nurse went in there all night, gave antibiotics. CNA went in there all night, did Q4 viral signs. They did all that. Looked so good in the paper. But the patient is drowning in their pool of blood. Nobody saw that. You can only see that when you turn the light on. Please be advocate for that. I'm very advocate for that. Turn that light on. You will do 99.9 assessment by just turning the light off. Turn it on and see the patient. That happened at, I'm not going to call the hospital. Patient was diabetic. This is not a joke. That's why I use these examples. This patient is a diabetic patient. The CNA went in, did viral sign. At the same time, I'm going in with my patient to show the patient how to do acupuncture. So we passed the CNA up at the door. Of course, she didn't turn the light on. So, of course, I went in there, poof, turned the light on. The patient was like this, drowning in sweat. So I told this, I just stood like this, looking at her. I told I was showing the student how to do acupuncture. We put the blood in the thing. It wouldn't even register anything. Right there and then, I called rapid response. Call rapid response in the room. He couldn't register. So it was so low that he couldn't register. This patient was saturated with sweat. The tech couldn't see that. All she was telling me, oh, I had to check her blood pressure 4 times. You know, we were passing the door. I checked her blood pressure 3-4 times. What kind of pressure are you checking? There's no pressure coming. The lady is dying. There's no sugar. The blood is being shunted to the vital organs. You can't get nothing. That's why you did the blood pressure 4 times. You still can't give me a real value. So turn that light on, please. If we did not turn the light on, I still wouldn't know what happened. I would be like, okay, nothing, this patient don't have blood. I go out there and say, well, the nurse, you're going to have to go do something else. We can't get this. By that time, the patient be dead. So I call rapid response. Because anybody can call rapid response. I don't care which hospital, I call rapid response. The people came, they said, oh, the sodium is low. This thing is low. Oh, I don't know. Who is the primary doctor? The doctors are asking one another. The other one say, well, I'm trying to see why the sodium is low. I'm looking at them. I'm just looking at them. The other doctor telling the other one, I don't know why sodium is low. The lady have ascites. So why the one you asking another? What? I was like, you should have asked my student. They would have told you the lady have ascites. The fluid is outside the stomach, pulling sodium with it. Ask my student, she tell you, I don't have to open my mouth. Ask her. But she was asking another, the doctors are talking. You just that tells you a lot about. I'm like, can we get B50 and give this lady before we talk about all this stuff? But anyway, turn the light on. When you turn the light on, you see a lot. So, wheezing, very important. When a patient is wheezing, they have asthma exacerbation. It's part of the disease. It is what happens with them. It's equally important we understand that absence of that wheezing doesn't mean your treatment works. They might be getting very sick. So watch for that. Coughing, of course, give them fluid, right? Give them fluid. If they're coughing a lot of sputum, it's time to watch their WBC and make sure they don't have infection. If they do, notify the doctor. Watch the color of the sputum. Is it clear, thin sputum? I won't worry about that. If it's clear, that's good. If it's purplish and start being purplish and yellow is different colors, then I worry about that. Because now, the patient is having infection to go around it. So anytime you call the doctor, you have to report the color of the sputum that you saw. The patient is spitting out greenish. Sometimes greenish is kind of like pneumonia or purplish infection or whatever color the sputum is, report it to the doctor. Because sputum shouldn't have color. So when it has color, it means something is going on with the patient. Sometimes it's brownish. They might be bleeding. So anytime you see any color in sputum, it's not a good thing. Autopnea. What is autopnea? The same principle with when they have COPD. I demonstrated that. They have difficulty breathing when they lie down. So the first thing you do is what? Sit them up. Sit them up. You're about to breathe better. Just up. Sit them up. Accessory muscles, again, when you control the wheezing, control the coughing, control their breathlessness, they will start relaxing. Because using the accessory muscle is they're using everything they have to get more oxygen in. So once you resolve those underlying problems that causes them not to have adequate oxygenation, they will start breathing better. They won't use the accessory muscles anymore. Anxiety is also associated with asthma. Because of that feeling of doom, they get very anxious. When we talk about medication, you see that MAR I gave you, one of them they prescribe as alprazolam for the patient. Alprazolam is for anxiety. That alprazolam is because they already know this patient have anxiety. Because of that breathlessness, bronchoconstriction of the airways, decreased oxygenation getting to them, they feel that feeling of doom. They have anxiety. They are very apprehensive. They're very agitated. These are signs of lack of oxygen there. Of course, mood swing, agitation, chest tightness. Give them medication. Bronchodilators. So bronchodilate. Bronchoconstriction is what causes the lack of oxygenation. Give them bronchodilator to bronchodilate the airways so that they can get more oxygen in, so they can breathe better. That can lower their breathing, so they can lower all the tachycardia and tachypnea can be lowered when you bronchodilate. When you bronchodilate, then the chest tightness will start being minimal or reduced. So this feeling of feeling of doom means lack of oxygenation. That's what making them feel like they're about to die. They don't know when the next oxygen is coming. They don't know if they're going to live the next minute because of that bronchoconstriction of the airways. So these are the signs and symptoms, and these are the interventions we just went over. Any questions on this? Any question? Okay, so let's summarize what you've done so far. These 2 lines. Tell me what you've done so far. One person will talk about the problem, another person the intervention. That's how we're going to do it. So this line, what are the signs? One sign. Huh? Thin mucus, the cough, thin mucus. So what will you do about the coughing? This line here. What is the intervention for a patient who is coughing thin sputum? What is the first thing you're going to do for a patient who is coughing thin sputum? Increase fluid. Coughing, sputum, fluid. This side. What else? What other signs do we have? Signs of, huh? Breathlessness. Okay, this line. What will you do? What is the intervention for a patient who is breathless? Go to breathing. Speed them up. What about this line? What are the signs and symptoms we have? Anxiety. This line here. What are you going to do for anxiety? What is the intervention? What is the intervention for anxiety? This line here. Alprazolam for anxiety. But what else can you do? What about this line? What else can you do for a patient that's anxious? Breathing techniques, right? Teach them about breathing techniques to slow the breath down. Well, I'm sorry, it's 2 of you. I didn't make 2 of you to be on the line. So, tell me the symptoms you know about. Orthopnea. Right. Orthopnea, sit them up. She picked the easiest one. All right. So, any questions here? Yes.
Would you do pulseless breathing?
You can do pulseless breathing. Well.
Or is that more for like getting the CO2 out? And so this is like breathe in, breathe out, same count?
You can do pulseless breathing. Yes, you can. Your book even talks about that. It talks about pulseless breathing, but it wasn't clear how that relates to asthma, as it was clear how it relates to COPD. That's why I didn't mention that. But your book says something about pulseless breathing, but did not really link it to asthma. And I will tell you why. Because with asthma, they have less PO2. So pulseless breathing, you don't want, it's not, you already have less CO2. It's not like you're prolonging the exhalation to be able to release more CO2. With asthma, it's less already. So it wasn't clear the way the book explained it. So I don't want to bring that in there. That's why I left that out.
So like as far as breathing techniques, is that just kind of like counting with them or
the cough and deep breathing, cough and deep breathing using the incentive spirometer, cough and deep breathe using incentive spirometer. Those things will kind of help. While they're doing it, they're concentrating on what they're doing, and then it lowers their breathing, their fast breathing for them. Good question. Anything else? Okay. Let's look at diagnostic tests. If you watch what I do, you do the patient signs and symptoms, do the patient intervention. Diagnostic test, medication. Lab values, this is how you study. You have to group these things like that. Otherwise, you skip something. And when you skip something, you're not going to get it in the test. Because the test covers all these. Signs and symptoms, intervention. Diagnostic test. Lab values. Medication. There is test. There's question in every section of these. So, if you're the type that just study just to study, you skip the lab, you already miss points or something. Or you skip medication, you're already missing something. Just going into the test, you're already missing it because you didn't study it. You see what I'm saying? Students focus a lot on signs and symptoms. And that's an aspect of it. You still have to know about the diagnostic test. You still have to know about medication. You see, you have to know it like that and study like that. Always study like you're about to teach the concept. This is something I learned at the conference I went last year. Students don't do well because they just study. If I ask one of you now to come and teach something that you know about. Trust me, you're going to study him better than you just studying to take a test on that same concept. Always study like you're about to teach the concept. If you study like you're about to teach, you do extremely well. Because if you study like you're about to teach, that means you're not going to know where the student is going to ask you questions. Therefore, you have to study everything. Everything includes medication, diagnostic tests, signs and symptoms, intervention. You see where I'm coming with that? Study like you're about to teach. That will make you study everything. Okay, so diagnostic test. We have X-ray, like we have in COPD. We have arterial blood gas. We have peak expiratory flow rate. We have pulmonary function test. That's one of the most common ones. That's one of the most common ones. So, what do you think the X-ray is looking for? If they have fluid in the lung, if they have infection, if it's clear or not clear, if they just have an asthma, exacerbation without any compromise to the lung. Arterial blood gas. You all have done arterial blood gas, right? Right? Okay. What is the normal pH? What is the normal PCO2? You remove the 7. 35 to 45. Bicarb, 20 what? 24 to 28. PaO2, partial oxygenation. SaO2. Huh? You see how only 1 or 2 people are talking about this. You have to know this value. You must know the value. That's aspect of life value I'm talking about. You must know data, numbers. You have to know the normal. If you don't know the normal, you're not going to be able to know abnormal. So, remember, when it's less than 7.35, it's what? When it's higher than 7.45, it's what? The patient that have asthma have pH that's greater than 7.45. They hyperventilate. As opposed to the patient that have COPD, they have less than 7.35. They hypoventilate. So hypoventilation, COPD, hyperventilation, asthma. Those patients, they have agitation, anxiety. Anything anxiety will increase their heart rate, increase their respiratory rate. You're going to start panting. That's asthma. They hyperventilate. Because they hyperventilate, their pH is what? High. Because they hyperventilate, they exhale a lot of CO2. Therefore, the PCO2 is what? Low. Hyperventilation. You're blowing off CO2 when you hyperventilate. Your pH is high because it's alkaline. That's a major difference between COPD and asthma when it comes to acid-base interpretation. They're both going to have decreased oxygenation because they have issue with oxygenation. But the major difference is the pH. Anytime you're trying to analyze any value, start with the pH first. You may not even need to look at the rest of them. If you start with the pH first, if a question is asking you about asthma exacerbation, you already know the pH is going to be greater than what? 7.45. So anything less than 7.3, I wouldn't even look at it because it's not asthma. The same principle with COPD. If the question is about COPD, I already know the pH is going to be less than 7.35. So if you start off with 7.4, I know it's not COPD. You see how that works? So for asthma, they hyperventilate, they pant, they have anxiety. Everything go up. Anxiety up, flight or fright or whatever. Anxiety go up. Hyperventilation, feeling of doom, apprehension, agitation, wheezing, everything is hyped up. Asthma, pH greater than 7.45, alkaline. PCO2 low because they're hyperventilating. They're blowing off the CO2. So when I draw the arterial blood gas, they're going to have less PCO2 because they're already blowing it off from the hyperventilation. Do we understand this? Okay, you said you did, so let me find that. I'm about to find that. These two lines here, with the exception of the two people in front, back there. Tell me what you know about acid-base balance on a patient with asthma. With asthma, the pH is going to be high because they hyperventilation. So that means it will be higher than what? 7.145. So what is happening to their PCO2? The last line, the last two lines. What will their PCO2 be? Huh? The PCO2 increase? Is that correct? These two lines? What made it not being correct? What is going to make it low? Because they hyperventilation, they breathing fast, they are hyperventilating, they're blowing off a lot of CO2. So when I draw the arterial blood gas, they're going to have less CO2 left. So it will be low. Which is opposite of what? COPD. Asthma is opposite of COPD. With asthma, pH is high, PCO2 is low. With COPD, pH is low, PCO2 is high. They're opposite of each other because you hypoventilate in asthma, in COPD, and you hyperventilate in asthma. Take 10 minutes break, come back at 9:05. We continue with the acid base, so we can understand that there. Okay, let's look at this question I have on the board. The patient with asthma came to the hospital. How will the nurse interpret this value? pH 7.48, PCO2 28, bicarb 25, PaO2 68, SaO2 90. So what does this patient have? Anybody? Not you. Anybody else? What does this patient have? What kind of imbalance is this? I want the whole thing. What kind of imbalance is this? Okay. Again, start with the pH. Always start with the pH. You can look at the pH. You may not even have to look at the rest of them. The pH is 7.48. What kind of patient have pH that's high? It's higher than the normal. So what kind of patient have that? So if the pH is 7.48, what is it? Is it acidosis or alkalosis? So PCO2 is low because they're hyperventilating, they're blowing off the CO2. So what kind of imbalance is this? Huh? Respiratory? What? You see how we broke it down? Start off with the pH first. Once you look at that pH, it comes late in the beginning and late in the break. Close my door, please. So pH is high already. So once that pH is high, it shows alkaline. The PCO2 is low because they're hyperventilating, they're blowing off CO2. So this is respiratory what? Alkalosis with hypoxia. With hypoxia, because the partial oxygenation is low, SaO2 is low. 90 is low for patients that have asthma. 90 is normal for a patient that have what? COPD. That's how you do that. Start out with the pH, it tells you a lot. Okay. Now this is another question I made up. A patient with asthma arrived in the hospital with wheezing, breathlessness, O2 sat is 93%. Which finding will concern the nurse? Which finding will concern the nurse? A, patient is coughing. B, patient refused breakfast. C, patient takes break with talking, in between talking. D, inaudible wheezing. Which finding will concern the nurse? How many of you say patient is coughing? Show by raising up your hand. Okay. How many of you say patient refused breakfast? Show by raising up the hand. C, patient takes break with talking. Show by raising up your hand. D, inaudible wheezing. Show by raising up your hand. Why? Because the inaudible wheezing is a sign of respiratory distress, right? Inaudible wheezing is a sign of constriction of the airways. Okay, very good. You see how you get that? Patient refused breakfast. What have it to do with anything? Patient is coughing. That's part of the disease already. They can cough. That's fine. It's part of what's going on. Any of you here can cough. I can cough. That doesn't mean I have asthma. Good. So let's continue. Let's do one more. Let's do one more example. A patient with which finding indicates to the nurse that a patient with asthma is getting worse. No, you're not going to be able to get this. Let's talk some more stuff. You get this. Yeah, let's go over stuff. You get this later. You get it. Okay, arterial blood gas done. Peak flow meter. How many of you have seen peak flow meter? Or have seen any patient with that? Peak flow meter is what tells the patient that have asthma the next action to take. The patient that have asthma, they need to establish their baseline. They need to establish their personal best. So when they don't have exacerbation, they need to take a deep breath and exhale it through this peak flow meter and record what numbers they have. They need to do it 2 to 3 times a day for a couple of weeks and establish their baseline, establish their personal best. This personal best becomes a marker that will let them know when they are very sick. This personal best becomes a marker that let them know what action to take next. So with peak flow meter, what does green mean? Like in the green light, like the street light. Green means what? Go. Green means go. So that means this patient, the normal one is 80 to 100. It's the normal percentage you need with green. What does yellow mean in a street light for somebody who obeys the rules and regulation of the street? Caution. Caution means 50 to 80. What does red means again for somebody who obeys the rule? Means what? Stop. Stop means less than 50%. These things are in percentages. So when the patient wakes up one day, don't feel good, they just don't feel right, they take a deep breath, they inhale it in this peak flow meter. You can see green, yellow, red marker. Gives you an indication the level, which number the patient has. So when you take in a deep breath and exhale, if it falls within 80 to 100% of your personal best, that means go about your business. Don't call in sick. You're not sick, go to work. Go drop the kid off in school. Go pick them up. You're not sick. Because the peak flow meter level is between 80 to 100% of your personal best. If it's a yellow, means caution. So if it's between 50 and 80%, it means caution. It means go ahead and take your inhaler. Take your medication and watch yourself. Go ahead and take your inhaler. Slow down. Watch yourself. But do what you're doing. But go ahead and take your medication and slow down and watch yourself. Caution. If you're taking a deep breath and inhale in this peak flow meter, it comes up less than 50%. That means what? Stop everything you're doing. Take your breathing treatment. Recheck your peak flow meter. If it comes up to between 50 and 80, again, caution, watch yourself. If it does not come up to 50 to 80, it's still less than 50, what do you think you need to do? Huh? Go to the ER or do what? Call 911. Always remember, call 911. You're driving to the ER, they're right there. Remember that thing they showed in CNN? I know you today, you don't watch CNN. You all watch other stuff. I'm not even going to go there. But in the news, there was this man speeding. The wife was in labor. So the police stopped the guy. The guy said, police, I don't even have any leg to stand on. Yes, I was speeding. You can give me a ticket. The next thing you know, the man was about to write the ticket. The woman in the back, he yelling, yeah, baby is coming out. The man dropped this ticket, went back to his car, got towel and gloves, and delivered the baby. Right there and there. So, you might say, go to the emergency room, but look what happened to him, deliver the baby. At least this is a good result. But if you have asthma exacerbation that's less than 50% of your personal best, you want to call 911 because they need to give you treatment and route to the ED, or you're going to die. You don't want a complete occlusion of the airway. So, if it's red, use the inhaler. Recheck it. If it falls in the yellow, caution, watch yourself. Do everything you're doing in yellow. Use the inhaler, caution, watch yourself. But if it continues less than 50, go to the, call 911 and go to the emergency room. So this is a good tool for every patient that have asthma to use because this is what tells them the next step to take. This is what encourages them to know what action to take. Peak flow meter. The pulmonary function test, is the test that's done in the hospital to see how the lung is functioning in general. Any question with this? Okay. Let's make sure we remember these things. Medication. See how we go into the next thing, which is medicine. Medication. Remember, bring your medication book that I gave you. Those patients, albuterol. Remember the medication book, the patient in the medication sheet I gave you, the 2 sheets I gave you. Let's look at them. Those 2 MAR for patient. Let's look at them. Albuterol, prednisone, or methylprednisone, could be methylprednisone, prednisone. Okay, if you look at this medication on this paper, we have guaifenesin for coughing. Okay, albuterol, what kind of medicine it is? Short-acting beta agonist. Anytime a patient have, every patient that have asthma have to carry their inhaler. This is the albuterol inhaler. You have to carry this inhaler. And we need to know how to use these things. I made a copy and gave it to you. That copy is straight from your textbook. Albuterol inhaler. You shake it, put it in your mouth, take slow deep breath in, hold it for 10 seconds, remove the inhaler, exhale. If you have to take 2 puffs, you have to wait for 2 to 3 minutes between puffs. Why do you think you have to wait between 2 to 3 minutes before the next puff? Let the medicine get to the first one, get to the lung before you use the next one. You have to hold it for 10 seconds after you take the breath in. Why do we hold it for 10 seconds before we exhale? Why do we hold our breath for 10 seconds? So that medicine can stay in the lungs so you don't exhale it. Very important we identify how to use this medication. So, for using the albuterol, you can use all this medicine via dry powder inhaler or metered dose inhaler or nebulizers. These are the ways the medicine can be given out. So, this is metered dose inhaler, MDI, metered dose inhaler. It's one way of giving this medication. You can have metered dose inhaler with spacer. This is spacer. What the spacer does is make sure that the medicine goes straight to your lungs. It doesn't stay in your mouth. So the spacer increases the amount of medicine that gets into your lungs. So this is called spacer. This is metered dose inhaler. You can use it by itself because it has the mouthpiece, or you can use it with the spacer. Maybe about 4 or 5 semesters ago, I have a patient that have asthma in the class like this. So I was talking about this, so I asked her, do you have the spacer? She said, no. She said, well, my primary doctor recommended me for the spacer. When I went to go check for this spacer, it was $200. Now tell me how this thing is $200, this piece. That's why the student don't have that. So I said, guess what? I'm going to teach this. That's why I get all this stuff. I saw one respiratory therapist in the hospital. I said, Ma'am, do you have any spacer you can spare? I didn't lie. I asked you, do you have any spacer you can spare? She said, sure. By the time I turned around, she came with spacer like this in a pack and gave it to me. Guess what I did when the student come on evening shift? Here, $200 for this crazy stuff. Something that works so well for the patient. Why can't you give it to them so that they can get adequate medication, so they don't have to be sick to come back to the hospital? This is how I reason. But these insurance people, they don't want me in there because somebody will wait for me in the parking lot and shoot me. Because I will give them all the rationale in the whole world why they should be given this thing. And the real rationale, I'm not going to lie. If you're telling me this makes the medicine gets better in the lungs, the patient feels better, don't you think you need to give it to them so that they feel better? They don't get sick. Then you get your money more. You get more money because the patient goes to the hospital less. You make more because they're in the hospital less. No, they're not going to give it to you until you're about to die. So, but the spacer helps in making sure the medicine gets to the lung. But it can be used by itself, inhaler, with the mouthpiece, without the spacer. So, albuterol. Then we have the dry powder, DPI. This is the dry powder inhaler. It comes like a pill. You put the pill here, you close it. Once you close it, it deactivates the pill. It crushes the pill. Then you put the mouthpiece in your mouth. You take a deep, fast, deep breath. With dry powder inhaler, you have to take deep breath. With metered dose inhaler, you have to take slow deep breath. Slow breath. Dry powder, fast and deep. Because it is the fast and deep breath is what deactivates converts the pill into aerosol for you to be able to inhale it. So you have to go in the lung like through via aerosol. So it is that fast, deep breathing converts that into aerosol as you're inhaling it. Again, hold it in your mouth after you inhale it. So dry powder inhaler, metered dose inhaler. Metered dose inhaler with spacer. Then another way that you can give that is via nebulizer. You see this a lot in the hospital. Respiratory therapists will put the albuterol in the canister, close it up, put it in the patient's face. You see this a lot, they're inhaling it. They plug this to the oxygen in the wall. They can send oxygen to 10 liters as they're giving the breathing treatment. So this is called their nebulizer. All these things are inhalation. It works better than Pures because it's aerosol, it goes straight to the lung. Not only it works better for the patient, it's faster because it's via inhalation. Not only is faster, it causes less side effects. Because albuterol, what are the side effects of albuterol? Anybody? Increases heart rate. It can cause tremor. Those patients tend to shake a lot. It can cause tremor. It increases heart rate. So when you get it via aerosol, it kind of like it causes less systemic effect on the body. So 3 ways of doing that: dry powder inhaler, metered-dose inhaler, nebulizer. And I have demonstrated them to you. I even gave you a copy to substantiate that. And that copy is from your textbook. If you don't remember anything, anytime you have any concept, look at the table in the book. The table in the book is the gist of that whole concept. The table in the book, there's a reason why the people that wrote the book made a table. The table gives you the gist and the summary, the most important thing in that chapter, in the table. So any concept you study the table, if I were you. Always look at those tables, because those tables are the gist of the concept. Those tables are the most important thing in that concept. That's why the authors put them in the table. That's the reason why you have tables. Table is the summary of the concept. Table is the summary of the chapter. Table gives you the gist of that chapter. So always look at the table. I'll be giving you all the tips, but I can't write the test for you. That's the only thing I'm not going to do is write the test. So short-act beta agonist. It kicks in immediately in minutes, albuterol, or lev albuterol. Kicks in minutes. It lasts 4 to 6 hours. So it's fast-acting. That's why when a patient comes with exacerbation, you want to give them fast-acting. You don't want to give them something that will take too long to act. Hyperprotein bromide. What type of medicine it is? It's long-acting beta agonist. It's also anticholinergic. Anticholinergic. It's long-acting. It takes up to 60 seconds to 90 before it can start kicking in. You don't want to give that for patients who have exacerbation, but you can give it for maintenance. Patient can be taking long-acting medication on a daily basis to prevent them from having exacerbation. You can have a long-acting in conjunction with fast-acting, but you cannot take the long-acting by itself when a patient have exacerbation. And then you cannot give it hyperprotein propium bromide for a patient that have glaucoma because it increases ocular pressure. So you have to be very precautionary when you do that. Just like those patients that have asthma, you have to watch aspirin and NSAID. They cannot have those medications. They cannot have aspirin. They cannot have non-steroid anti-inflammatory. They cannot have beta blockers, OL, for the same reason. Because you need the beta cell. You see? Short-acting beta agonist. You need agonist. You don't need antagonist. Right? When you give it, what does beta blocker mean? You're blocking the beta. You don't want to block the beta. They need the beta. They need agonist. You don't want to block the beta. That's why you don't give them beta blockers, OL, because it's bronchospasm. So you don't give it to patients that have asthma because they need that beta cells. You don't want to block it. They need that beta cells when they're having exacerbation. That's why. That's why you're giving them beta agonists. You don't give beta antagonists. You give agonists. Because OL is antagonist, right? Do we understand the mechanism? The rationale behind why we don't give it? It causes bronchospasm. Prednisone. What is prednisone? Steroid. Prednisone is steroid, therefore it's an anti-inflammatory. It's an immunosuppressant. It can increase the bleeding. Those medications predispose the patient to bleeding. So we have to watch bleeding tendency for those patients. It can decrease potassium level. decrease potassium level. It can increase the fluid retention. Because it can increase fluid retention, it can increase blood pressure. Because it can increase fluid retention, it can increase weight gain. It can also cause osteoporosis. Immunosuppressants. Mood swing, like the patient we had. It causes mood swing. Moon phase. Anything else I'm missing? If you understand the concept of fluid, you're going to get this thrill at least. Increase in fluid means including weight gain. Increase in fluid means increased blood pressure. But they can decrease the potassium level. And then increased fluid means increased sodium level. You can increase their sodium retention. You hold in fluid, you hold in sodium. Increase fluid, increase sodium. Increase fluid, increase blood pressure. Increase blood pressure, increase weight gain. See how that go hand in hand? Everything you learned in one place, right? Everything you've been learning all semester. Osteoporosis, immunosuppressant, mood swing, moon phase. Those patients get to have like puffy face, puffy. They look puffy from prednisone. It can increase their tendency for bleeding also. They tend to have, like you start an IV under them, they kind of leak blood underneath the skin. They have a lot of petechiae, blood leaking out under the skin because of prednisone. Alprazolam is for the anxiety, guanfacine or cough syrup. Help them to suppress the coughing or help them to stop coughing too much. Any questions? We have talked about diagnostic tests, signs and symptoms, intervention, medication. All right. Signs and symptoms of prednisone. Because prednisone is a very good medication, you don't give it for a long period of time because of these signs and symptoms. Except those patients that have severe asthma. The doctors keep them on prednisone. Like the patient we had, she tells me she takes prednisone, very minimal dose at home. So we have to watch it. They don't usually give patients a lot of prednisone for a long period of time because of all these signs and symptoms, except if it's really necessary, they have to have that. Any questions?
What did it say after prednisone?
Guanfacine, cough syrup. Rubitazine, guanfacine. It's in the paper from the MAR I gave you. Yeah, from the MAR, guanfacine. Then from the MAR I gave you for that patient that have asthma. That's where I got all that medicine from. Because if we're using them in the hospital, we have to know them, right? That's why I gave you those two patients. We can see that they both take the same type of medication. And that's why I'm using those medications for us to learn from. So, a patient, okay, which findings indicate to the nurse that a patient with asthma is getting worse? Which finding indicates to the nurse that a patient with asthma is getting worse? The patient needs to use inhaler. Q 2 hours. B, pH 7.48. C, ambulating only 1 mile. Q day, only 1 mile. I'm just abbreviating all this stuff. Only 1 mile. Q day. D, audible wheezing. Which of these shows the nurse that asthma is getting worse? Anybody? How many of you say A? Show by raising up your hand. Anybody? Show by raising up your hand. 2. How many of you says B? Show by raising up your hand. I might just say like 10 or 12. How many of you say C? Show by raising up your hand. How many of you say D? Show by raising up your hand. 1. Okay, let's start from D. Audible wheezing. Does it show that the patient is getting worse? No, because it's part of the diseases. That's what brings the patient to the hospital. They're going to have audible wheezing. I worry about when the audible wheezing is inaudible. That's when I worry about it. So audible wheezing, I know you got it. I'm working on it. Ambulate only 1 mile a day. How many of us can even ambulate a mile a day? We barely ambulate a mile in 2 weeks. B, pH is 7.48. Why would pH in 7.88 tell me it's getting worse? That's what brought you to the hospital. If you have asthma exacerbation to come to the hospital, your pH is going to be 7.45. I'm not going to worry about it because that's what brought you to the hospital based on the option I have here. That's what brought you to the hospital because it's going to be greater than 7.45 anyway, so I won't worry about it. I know that's what you got. I'm working on it. It's normal for you, for the disease. Need to use inhaler Q2 hours. I already said that inhaler lasts 4 to 6 hours. Therefore, you have to use the Q 4 to 6 hours. If you have the need to use it every 2 hours, that means the Q 4 hour is too long for you. It's not working for you. You need to see the doctor right away. So, the ability for you to require the inhaler more often than you're supposed to use it means it's not working. You're very sick. You need to do something else. So, need to use inhaler every 2 is what I concern myself. I'm not saying you're using it every 2. You have the need to use it every 2. That means it's not working for you. We need to add something else there, or we need to call the doctor. Because it's supposed to last you 4 to 6 hours. But you have to need to use it in 2 hours. That means it's not working. That's a concern. You're sick now. I need to do something else. You see how that works? Okay. This is how these exams are, y'all. So if this exam, only 20%, only 2, we get it. That's how we do it. Then 2, we get it done. Then we're going to rack our brain. Why did 2, only 2 get it right? Why did 12 people pick pH 7.48? See, stuff like this, we don't touch it. Because students should have known 7.48 is asthma exacerbation. Now, if it's something that's so confusing, that's closer to the answer, we are like, yeah, I can see why they all pick B, well, then maybe we need to just change it. Give them B. If you put B and A, that's how we do these things. There's no magic. We don't look at nobody's face. We look at data. We don't know who have these things. We just look at data. All right. Okay, so let's see. Number 3 question. A patient with asthma arrived with, I think we did this. Yeah, we did that. Okay, so number 2. Which finding will indicate to the nurse that the patient understands medication administration? That the patient understands the medication administration. Use inhaler as needed. B, go to the emergency room at 60% peak expiratory flow rate. No, that's too much of peak flow meter. I'm going to just do it like that. C, use inhaler at 85% level. D, use inhaler at 40% level. And recheck. Which of these will let the nurse know that the patient understood how to use the medication? How many of you say A? Use the inhaler as needed. Why? Because, see, now you got this. If I had done this first, I guarantee you a lot of people will pick A. So you can't say use it as needed. You can only use it as scheduled, right? Q4. Go to the ER at 60%. At 60%, does she need to go to ER, he or she? No. What does she need to do? Caution. That's that 50 to 80. Use caution. Take the medication and watch yourself, right? Okay. Use inhaler at 85% level. Do they need to do anything at 85? No. Just go to work. Don't call in sick. Don't look for any excuse to be home. D. Use inhaler at 40% level and recheck. Yes. At D, it's already in red. It's less than 50%. You use the inhaler. Recheck your level and see where you are. See if you need to go to the call 911 or if you need to use caution and watch yourself. We understand this? Very good. All right. Okay, I think that's it. So let's go over the PowerPoint. See what we need to do. Oh yeah, this is that thing that's low. Asthma overview. Obstructive sleep apnea. I'm gonna just talk to it in slide since we don't have too much time. Recurrent. I take time to do these things because I know areas where students have problems. These things sound so simple, but they are not. That's why I'm taking more time. I'm like teaching you all how to answer these questions because students get confused with this when we already discussed that. So, recurrent episode of wheezing, we already went over this. Asthma. This is how those patients feel. They feel trapped in their airways because of those bronchoconstriction. Asthma trigger is what triggers the acute inflammation. We already discussed this. 4 to 12 hours before you actually feel the exacerbation. You have to have that trigger within 4 to 12 hours before it can manifest with signs and symptoms. Allergic reaction, we already talked about those. Tachypnea, chest dyspnea, we talked about those. The triggers, we already went over. Respiratory tract infection, that's what RTI means, can also predispose the patient to asthma exacerbation. If they have like bronchitis, respiratory tract infection, pneumonia, all those things can predispose them. We discussed gastroesophageal reflux disease. When something reflux in your airways, you can stimulate those patients to start having asthma. When acid reflux to your airways. Assessment, always assess the patient. We look at this. Like I said, they always cough. They may not have productive cough. Sometimes, as the asthma exacerbation goes further, they start coughing. Peak respiratory flow rate, I already spent a tremendous amount of time on that. Coughing, wheezing, we already did all that. Anxiety and apprehension, agitation, that's when they start pulling out things. They pull the IV out, or they start being restless. That's lack of oxygenation. Those patients, we have to watch them closely. Diagnostic test, peak respiratory, and we did this already. Pulmonary function, we did all this already. O2 sat is just the saturation you do in the hospital. Prevent, control, side effects. Pharmacology, I already talked about that. Different ways of giving the medication. You don't have to worry about, really necessarily where they belong to. We need to know the actual medication. And you need to focus on the ones we talked about. We don't have to know all the medicine in the whole world. We used to talk about the ones that are being used in the hospital. That's why I gave you all those MAR. These are just for you to kind of know, because to be aware that it's not just the one we discussed, it's the one that's out there. But the one we discussed are the ones that are most commonly used that we need to know. Does that make sense? Promote effective gas exchange. We discussed that already. Breathing. We talked about those already. You have to help them relieve the anxiety, calm them down through breathing, incentive spirometer, cough and deep breathing. Even ambulation helps as much as they can tolerate. Asthma that does not respond to all these treatments we discussed can lead into status asthmaticus. If the patient is not responding to the treatment for over 24 hours, they need to be transferred to ICU. So now that patient is going from respiratory alkalosis to respiratory acidosis. Well, anytime a patient that has asthma goes from alkalosis to acidosis, that means complete occlusion or near occlusion of the airways, it suppresses their respiratory center, suppresses their breathing. They're returning a lot of CO2 at this time. They are going into respiratory acidosis. It is a life-threatening situation. So patient can convert from respiratory alkalosis to acidosis, but at this time, it's a critical emergency because it's suppression of the airways. They need to be transferred to ICU. They're going into status asthmaticus, which is a life-threatening situation. Obstructive sleep apnea. Obstruction. The tongue might obstruct the airways, or uvula might obstruct the airways. When this patient lies down, it's not snoring. It is absence of breathing for 10 seconds for you to be qualified to having apnea. They have to have breathing cessation during sleep for 10 seconds. This patient will have a test we call polysomnography. This polysomnography, somebody watches them when they're sleeping. They hooked up on the monitor. You're looking at their heart rate, their eye movement, their leg movement while they're sleeping. To monitor if they qualify to have a sleep apnea. It's not when you are snoring. You have to have that cessation of respiration for at least 10 to 20 seconds. This is just telling you how the patient with sleep apnea look like. We're not going to spend time on that. Obstructive sleep apnea is the focus. You don't have to worry about central or mixed. It's just telling you we have different types. Obstruction means something occluding the airway when they are sleeping. It's usually the tongue that falls down when they're facing, lying down supine. So those patients need to lay on their side. They need to turn over and lay down on the side. This is the test I'm talking about, polysomnography. Records their heart rate, breathing, eye movement, leg movement, to see if they are qualified to be diagnosed of sleep apnea. Those patients that have obstructive sleep apnea, they keep waking up in between their sleep. That's why they have daytime sleepiness. They tend to sleep in the daytime because they didn't get enough sleep at night. They have headache. They have morning headache. They have difficulty staying asleep at night, insomnia, because of that waking in between their sleep. It can cause stroke. Those patients can have they are high risk for stroke. They are obese. They are 45% overweight. So, because the sleep apnea can cause hypertension, it predisposes them for increased risk for stroke. They are awake in the daytime. They have dry mouth because they tend to breathe from their mouth. It's a major, I didn't even know I have that. Increased risk for blood pressure, decreased oxygenation, and increase in carbon dioxide. Because they tend to snore, it suppresses their respiratory center. So those patients that have apnea stays in respiratory what? Acidosis. Anytime anything suppresses respiratory center, it's acid. It makes you retain more CO2. Therefore, they have respiratory acidosis. Those patients with sleep apnea. Educate them on weight reduction because they're mostly overweight. Those patients cannot have sedatives because you don't want to sedate them when they're sleeping. They're already waking up in between sleep. You do not want to give them sedatives. They need to avoid alcohol because alcohol is like a sedative. It makes most people sleep. Avoid supine position. They need to turn over on their side. Those patients use a BiPAP or CPAP machine. How many of you have seen CPAP in the hospital? CPAP machine is the machine that they wear to open up their airways. That's all it does. While BiPAP, and CPAP, they look alike. Those machines look alike. You won't even know any difference when you see them. But what BiPAP does, it helps with air going in and air coming out in the patient. In and out. While CPAP has to do with continuous air getting into the patient. These patients still have to take in the deep breath themselves. The machine doesn't breathe for them. It assists them, making sure the airway is open. Patients still have to inhale and exhale. So those patients, sometimes they feel claustrophobic because it's a big thing in their face. Educate them on how to relax, breathing relaxation. They need to have like a breathing relaxation before they can have the machine because they need it to keep the airway open when they sleep. So CPAP or BiPAP machine also can cause dry mouth. So you need to humidify those CPAP machine. It can cause dry mouth, humidify them. Those patients that feel claustrophobic, teach them breathing relaxation to relax so they can be able to use the machine. You do not give them sedative again because they have to be awake. Patients that use CPAP or BiPAP machine has to be patients that are oriented. You cannot give it to a confused patient or a patient who is sedated. You cannot give a patient that's restrained in the bed CPAP machine. If they are restrained in the bed, they cannot have CPAP machine. If it's a patient that cannot breathe on their own, they're confused, they cannot have CPAP machine. Because you have to be alert, patient that's oriented, alert, because you need to be able to cough, you need to be able to talk, you need to be able to do those safety measures for you to be qualified for CPAP machine. No sedatives. They can have surgical intervention also by taking the tonsils out or anything that the doctors feel like is in the way. So it's very important that those patients with sleep apnea, we watch them because they're high risk for stroke. Monitor their blood pressure, turn them on the side so that the tongue falls on the side instead of occluding the airways. CPAP machine, you have to be awake, alert, and oriented. You cannot give it to somebody who is confused. CPAP machine cannot be given to somebody who has like trach or somebody who is not oriented. They have to be oriented. They have to be able to be coughing. They have to be able to use the machine properly. If they feel claustrophobic, educate, because claustrophobic makes people to be anxious. So when they are anxious, they tend to breathe fast. So educate them on that breathing. Slow down. Take a deep breath. Go ahead and use it. It's okay. Any question?